Hi, everybody, and welcome to this edition of the Dr. Keith Darrow podcast. Today, we welcome Kathy Dowd. Many of you in hearing healthcare know her as she has been very prominent and I think instrumental in sort of bringing hearing healthcare to the forefront, helping more people understand, be it the connections of hearing loss, balance, diabetes. I know, Kathy, you've worked with the CDC, so you've had a very long and illustrious career, and I just want to thank you for everything you've done.
Oh, you're welcome. It was my pleasure. Once I retired, I had time. So, yes.
So tell me about yes, you are quote unquote retired now. I've yet to meet people with as much passion as you who ever actually retire and just go sit on a couch somewhere, right? I know you're still busy, but tell me a little bit about your story and how you got to here.
Well, actually, it has a long history, the issue of diabetes and hearing loss, because back in 1993 was when I applied to become a Medicare provider, and there wasn't any material on what you needed to do as a Medicare provider, as an audiologist. So I called them, and the lady said, "Well, honey, what do you do?" I said, "Well, I test hearing." She said, "Well, you need a doctor's order." I said, "What does it need to say?" She said, "Well, whatever you're going to do." So that was the extent of the information I was given. Although then I also saw we test for the purpose of illness, injury, trauma, and complaint. So, with those four things, I also had just sold a Miracle Ear franchise. So I had a 3-year non-compete. So I couldn't advertise. And I discovered nursing home work. Somebody called my office, needed somebody tested. And that's when I discovered a huge, huge issue that I tried to correct back then, but I got stomped on. So
Sure. How did you come into, right? There are a number of comorbid conditions that go along with hearing loss. And our field is, I want to say this the nicest way. Sometimes we're very laser focused. And right, what's the cool thing right now? Cognition, right? But we're still not doing a good enough job at really marketing the connections of hearing loss and diabetes, hearing loss and cardiovascular disease, right? There are 130 million people either pre-diabetic or diabetic in our own country. That's a lot of people with increased risk for hearing loss. So how did you start this push so long ago?
Well, for diabetes, obviously back in 1993, I just started looking up things that were contributors to hearing loss. And you go into a nursing home, you look at their face sheet, and you see all these diagnoses. So I knew I was on the right track there. This recent last decade of work that I've done was because of my mother-in-law. She was in an assisted living. She was probably mid-80s, and she had a recent diagnosis of diabetes. So she already had a heart problem, cardiovascular problem. She had hypothyroidism. She was on Lasix. And so when she got this diagnosis, I drove out to Louisville, Kentucky, where she was, and my brother-in-law came down from Michigan. And so we were, he was running around talking with the kitchen staff about her diet, making sure it was right for diabetes, and talking with the nurses about taking her blood and all that. And I said, "Richard, we need to keep a closer check on her hearing." And he said, "What are you talking about?" I said, "Well, diabetes causes hearing loss." He said, "I've never heard that." And he was in charge of the diabetes program in Michigan.
Oh my gosh. I thought you were going to say he was some true lay person who, I don't know, lays bricks or something for a living.
He doesn't want me to say his last name, but I said, who gives you your information? And he said, "Well, CDC and ADA, the American Diabetes Association, they're the ones that fund us." I said, "Okay." So I reached out to CDC, the info at cdc.gov, and said, can you send me information about diabetes and hearing loss? So they sent me stuff about diabetes and stuff about hearing loss. I said, no, I want the link. And after bugging them for about a month, I got an email from Dr. Pamela Allweiss, who's now on our board. And she said, can we talk? I said, sure. She said, when we talked, she said, all of my colleagues elected me to call you because we've never heard of this before. So I started sending
We
her.
won't say any of their last names either.
Yes. So, I mean, that's when the ball started rolling. And, you know, it wasn't until that was 2011. It wasn't until 2016 that she told me, well, we're going to put in a recommendation that people with diabetes see a hearing specialist. And I wrote back and said, no, you need to say audiologist. And she wrote back,
all right, fair.
And she said, well, people won't understand the word audiologist. I said, then you have to explain it. So then she kind of went dark, and I realized I needed to do something. Something was going to break. So that's when I got the 3 audiology group, well, ASHA, AAA, and ADA together at the table with AOA, the diabetes organization, the diabetes educators organization at Salus University. We all got together for a meeting, and just that's when we got writers that in 2019 had a full series in seminars in hearing, the November, explaining all the aspects. Well, not all, we still don't know all of it.
Sure. Yes, sure.
But a lot of what's going on with diabetes, hearing, and risk of falls. See, I wasn't even considering risk of falls, and I thought, I need to look that up. And sure enough, it contributes to falls. So I reached out to Richard Gans and said, can you come up to this meeting? He said, certainly, not a problem. So he came up and presented. But that wasn't even on my radar. And now auditory processing. I mean, the fact that you've got a disruption in small blood vessels in your brain occurring with diabetes throughout your whole body, but in your brain, that's going to affect the auditory signal. So we need to be very aware of not just doing an audiogram, but, you know, a full spectrum of auditory processing.
Sure.
What's going on.
Well, yeah, I mean, the audiogram is so minimal at this point, right? I mean, we've really, thankfully, I think we're starting to, again, I don't think we're throwing the baby out with the bathwater, but I think we're starting to understand its place and how minimal it is, or just it's part of one of many things we must do during a comprehensive diagnostic evaluation and cognitive screening.
Yes. I need to know a little bit more as far as pairing those two together. Again, I've not been in practice since 2014. But what is happening in nursing homes is speech therapists are doing cognitive evaluations without ever screening hearing first.
Right.
And now I'm a nursing home ombudsman. So I'm in the nursing home talking with the residents.
And there's really undeniable proof at this point. I mean, all the data is out there, all the peer-reviewed literature. I mean, just to sum it all up, that dementia and hearing loss, if you put the symptoms side by side early on, they're identical, right?
Yes,
I mean, nearly identical. And so I'm very proud of the work we've done in our community. If you went to the local Alzheimer's association, which is a great resource for many families in the community, one of the very first things they will say to you is, have you had your hearing tested? And if so, are you treating your hearing loss, right? Because we can't just ignore that factor. It's such a huge role in socialization, cognition, memory, etc.
Yeah, when I worked for 21 years in nursing homes, and I would get feedback from the staff. It's like, oh my God, that was transformational. Some guy that used to fight with his caregivers when they came in to give him a bath and everything. Well, they were taking his clothes off. He didn't know what they were doing. So he physically was fighting with them. And when I told him that he needed hearing aids, they said, oh, I don't think that's going to work. I said, well, let's try it. He's got a severe loss. And when I came back a couple weeks later, I said, how's he doing? They said, oh my God, it's night and day.
Yeah.
We can go in his room, have a conversation, no more behavior problems. But what doctors are doing, and CMS is now focused on, is doctors are treating these residents, I think, with underlying hearing loss for mental illness,
Yeah.
for schizophrenia.
Yeah.
I mean, they do look disordered. They are talking crazy.
I mean, what a perfect visualization, right? Excuse my language, you're a grown ass man and you're in your private space and somebody comes in, you don't hear them, you don't know they're coming, and they go to take your clothes off.
Yes.
Yes. Just try to visualize that anybody in their right mind is going to fight back if that were to happen, right? And of course, now that person has anger issues, schizophrenia. I mean, it's so disturbing. I want to share a story with you, and I would love to know if you've had any experience like this. Now, I won't say any names or organizations, but I was once speaking with director of memory care in a nursing home, assisted living type facility. And she said to me point blank, Keith, I believe in you and everything you do and what you preach and the lives you change. But here's the problem. The reason I can't bring you in to help my patients is because administration knows that you're going to come in, that you're going to treat them, that they're going to need hearing aids, they're going to need something. And what if we lose them? Right? This is a huge financial liability on us. And we're just not willing to take that chance of, let's say, 8 out of 10 patients, 80% of patients get hearing aids. And now all of a sudden we're responsible because they get lost. And I was so deflated by that.
Well, that story doesn't surprise me because I've heard the same thing. I've heard administrators say, we don't have anybody with hearing loss. We have 90% cognitively impaired. Or another administrator said, well, ours is 50% cognitive and 50% behavior disorder. It's like, I think you need an audiologist, but it's mandated by federal law. Our services are mandated. That's the disconnect in there. Nobody seems to know OBRA 1987 mandates our services, even to the point of saying to the facility, and you have to pay transportation if necessary. Now, I would always go to the facility because I could see more people and look at their charts, and I wanted to look at their charts. But
that's if a facility lets you in and goes through the what's it going to take to get, a lot of the assisted living nursing home, right? If you really peel back the layers, they're typically owned by a parent company. What's it going to take for an audiologist to be hired by that parent company and perhaps be responsible for a few hundred patients in, a quadrant of the Carolinas or up in New England? I mean, what's it going to take to get there and to realize how important it is and take on the liability?
Well, what I learned in the last year, which I never knew, in 1999, there was also a Supreme Court decision that mandates our services in all living situations, not just skilled nursing. OBRA is for skilled nursing, but assisted living, group homes, even independent. And states have to cover the cost of hearing aids for these residents. Yes. Even if your state does not cover Medicaid adults. That's what I'm working on right now, is to go through, there's 21 or 22 states that have no coverage for adults on Medicaid. There is a hidden door and nobody tells you where that is. So I'm trying to kick down all those little doors in each state so that at the point an audiology clinic says, yes, I do want to get into that space and I do want to help those people. It's a huge need.
And the thing is, look, my specialty is in private practice working with adults. I consult with over 100 practices that have that very similar patient, and every single one of them, because really, audiologists, you've probably heard this before, we are loving, caring social workers that focus on the ear. So I don't know a single business owner or audiologist that doesn't want to get into that space. They want to go help. They want to set aside a day a week for a provider to go travel and provide that service. But financially, it makes no sense. And there's no, I just learned something totally new. And why am I just learning this?
Well, and back in 1993, when I started, I didn't tell anybody. I thought, well, I'm going to use it for myself, but I wasn't on a national. But now Hearing Life has learned about this in 2019, and they are blossoming their clinics in North Carolina, because you can set up a clinic anywhere and support yourself on the nursing home or assisted living work that you're doing, and then create more of a venue with or marketing to the general public in that area. So it is a great way to grow. And it does work. In fact, any service that an audiologist provides under their scope of practice can be billed in this manner, at least for nursing homes, maybe even for assisted living. So auditory processing testing, auditory processing rehab, cerumen management, special testing can all be billed. If it's not covered directly, you bill it as an unmet medical need, essentially.
So I'm just going to ask, I'm point blank, right? Patient needs hearing aids. What about that?
Yeah, it's covered. And if they don't have a set plan, so like some states already cover Medicaid adults. So you go under their process for the hearing aids. The audiology is separate. But yeah, I build my usual and customary for.
So they can, and so it would fall under Medicaid. In my state, that would be like Mass Health. They would fall under that pricing category.
Where are you again?
Massachusetts. So we call it Mass Health here, our Medicaid system.
Okay. So.
And they do cover hearing aids.
For adults. Okay.
Yes.
Yeah. So you're, and I don't know what your reimbursement is, but there may be a fee that you could charge for going out there. I don't know.
Sure.
As an unmet medical, you could charge your other services that may not be on the list of services they cover. Like, I don't know if cerumen management is.
Sure. Yes. Yes.
It is covered or not?
Yes, it is.
Okay. Auditory processing testing, rehabilitation.
I don't know.
Yeah.
I don't know.
So you really have to do a deep dive into what they cover and then what would be the ancillary. And, because we need so many people, and because for some reason in 2016, it was the end of my tenure as a ASHA board member. And I asked the lady next to me, I said, why isn't ASHA more supportive of audiology? And she said, well, you have to understand there's 180,000 speech therapists and there's only 15,000 audiologists. So we have to allocate our money proportionately. So we're sunk. And now, do you know what's happened since 2016? There are 220 speech therapists. And now they're telling me, well, they're under a lot of pressure. They can't screen hearing because, it's hard to find jobs and they don't want to get fired. And I'm thinking, that's bullshit.
Yeah. Yeah. No,
that's bullshit.
Yeah.
They can't withhold their services just because they can't do a hearing screening.
Of course. That's not cool. I'll just leave it at that.
Well, yeah, that eats into their revenue. So
yeah,
I
want to get back to two things that I made a little note that I want to get back to. How do we? So your story, what intrigued me about your story was you learned, as did I, out because of your curiosity, because of your digging, you out of school learned about the connections of hearing loss and diabetes and balance. It really shouldn't be that way. right? I mean, how are you not coming out of a clinical doctorate? Now, I don't know that you did the clinical doctorate. I went through the master's. I'm sure our programs were similar, but even nowadays, it's not as if the new crop since 2007 of audiologists have really come out with a stronger understanding of the medical side of audiology.
Well, and you had, an interesting thing about that is there's always a medical reason for that hearing loss. Always.
Always.
You have to dig. Maybe it was a traumatic car accident 10 years ago and nobody checked your hearing after it. Or you fell and hit your head and nobody checked your hearing. So there's always something in the history that you can point to that may have been traumatic or septic infections or, medications, all those things. You just have to look at the whole history, but there's always always a medical reason, and you write it down, and that's the reason you're going to be following this person.
Yeah.
I've had people say, oh no, people are telling us we can't see this person every year. Yes, you can, if you have a medical reason and you just write that in your medical reason. Retest in 12 months due to diabetes.
So what do we do? What do we do, right? Because the aging population is just, it's out of control in a good way, right? We're living longer. I mean, it's something to celebrate, but our field is not keeping up with that demand, right? There's not nearly enough of us to treat the 50 million people that are living with hearing loss. Like you said, 15,000 at most. I think it's somewhere between 10 and 12 that are actively working. I mean, how do we change this, right? I was approached by a private university to start an audiology program a few years ago. And they said, all right, so we're going to crank out about 40 to 50 students a year. And I was like, sounds great, but the average program puts out about 10. And even that, we're sort of saturating the market. So
we shouldn't be saturating the market. I mean, the need is so big.
I know, but I'm with you. I'm in agreement with you. And I agree with that university. It would be great to pump every university. If they pumped out 40 to 50, we still wouldn't meet the need. But, I mean, it's an economy of supply and demand. And how do we change this, Kathy? Well, I don't know if you have the silver bullet, but if so, please tell me.
I'm creating a few silver bullets. I'm not there yet. But if you look at the numbers just in North Carolina for nursing homes, sure, not assisted living, there are 425 facilities, at least pre-COVID. There might be fewer now because some of them closed. But then you look at, on average, 10 new admissions every month. And you multiply that times 12 months. Those are new admissions coming in. Some of them may go home, but in OBRA says you're tested within 4 days of admission for hearing. Mm-hmm. 4 days, nobody's doing it. Our state law says within 12 days, they have to test for hearing and vision problems. So that's just short-term care. Then you look at those 425 that have on average over 100 long-term care residents. We have 700 licensed audiologists in North Carolina. Do you think we need more to cover that need?
But let me ask you a question though. Let me ask you know the number, so maybe you know this one. 425. How many of the 425 employ a full-time audiologist?
Oh, none of them. They may contract for services, but sometimes it's only the ones they think have a hearing problem. So there's a
you see what I mean? Like, so how do we, right? Because so obviously that's where we have to make the change. And if we made that change and all of a sudden there were 425 new postings for new audiology positions in North Carolina, multiply that by 50 states. Yeah, now we can start pumping them out of the programs.
Well, I think we're close, though, because I've also been talking with CMS. I wrote a letter to the director of CMS in 2020. Out of that, just expressing my concern about this. Within 2 months, I had a meeting with the top people at CMS. I don't know if it was Zoom or something. And I explained, you've got this wonky CMS MDS hearing assessment. It's not valid. For the assessment nurse to go into a resident's room and say, Mr. Smith, can you hear me okay? And he says, yeah, I hear you pretty good. And then she marks his hearing as fine. I said, that's not valid. I've had multiple conversations with them. They know my name.
Good.
They wrote an email to Senator Burr, who is since out of office, and it basically admits, for the first time ever, the CMS MDS hearing assessment is not a hearing assessment. It is a subjective observation that may lead to recognition of a hearing problem.
See, now you're speaking my language, which is right. For the medical field to think a hearing test is, hey, can you hear me? Right? That's like saying, do you have any pain in your back? No. Okay, let me check the box. You don't have pancreatic cancer.
Yeah.
Right? I mean, it's that offensive, because we've got to get out of the mentality that hearing is a luxury. It's okay if you lose hearing as you get older. It's so wildly offensive that we don't all accept hearing loss for what it is, as a progressive degenerative disorder. It's a chronic medical condition that significantly impacts social, emotional, physical, and cognitive health. So quit the crap, right, with this bedside test of here. I'm sorry, I'll get off my soapbox, but I mean, this is it's so frustrating.
Oh, I'm with you 100%, 100%. I mean, would a physician who has thinks somebody has a problem with their heart, would they go ahead and say, you know, all your symptoms kind of lead to the fact that you've got this heart problem and I need to operate? Would they just go ahead and schedule the operation, or would they then do all these scans, all these tests, all this blood work to confirm what they think it might be?
And so they would be held liable if they didn't.
So as a cognitive, if you think it's a cognitive or a mental health issue, then vet hearing. That's so fundamental to everything that resident's going to show and exhibit.
I love that, Kathy, right? Do you suspect this, whatever the client, resident has memory issues? First box, check their hearing. Yes. Like really check their hearing, not, not the test we just talked about. Wow. Incredible. Look, we have a few minutes left here because these conversations can turn into hours and hours. And I love how aligned we are. I want to ask you I want to challenge you on one thought though, because here we are talking about the lack of us to help all these patients in all of these different facilities. You made one comment earlier. I'm going to paraphrase because I don't remember it exactly, where the person you were working with, I think at the CDC, said, okay, well, we're going to recommend they have their hearing tested by a specialist. And you said, no, it's got to be an audiologist. I can interpret that in 100 ways. I think the sort of obvious assumption is, are you intentionally keeping the hearing instrument specialist out of? No. Okay, you're shaking your head no. Okay, so what did that mean?
I think audiology needs to be seen as the experts. When I go to my eye doctor, she's the only eye doctor. She has a 5, 6, 7 staff that deal with the glasses and the paraphernalia and everything, but she figures out what's going on with my eyes. And so, no. I think we should be grabbing graduates, graduates from communication disorders programs and start getting them into a dispenser's role to learn how to test, to go out there and be boots on the ground, because when they go into audiology, and we should support them, support their tuition if they successfully, complete an AUD program, but they are going to be so knowledgeable when they walk in the door of a university for an AUD after having that practical experience as a dispenser. So no. I think that's almost a given, a mandate.
Okay.
We have
Okay.
to do
Good.
that.
Good.
Yes.
I'm so grateful that you said that, because there's more private practices, sort of on the hearing instrument specialist side than there even are audiologists, right? We've got to come together. I mean, don't get me wrong. We have to know our roles, and they're different, and our education is different, and what we can do is different, but that's okay. I thought we were supposed to embrace the diversity, right, of who we are. If so long as we're all rowing in the same direction, we stick within our guidelines, we don't, cross the line. We need a better symbiotic relationship. We need to better rely on each other, because there's just too many patients falling by the wayside. And I love what you said, because again, I won't say names, but people send me screenshots of stuff that people say about me all the time. And one of the ones that I got a really good laugh at was a couple of audiologists talking, and they said, and Keith, he tells his students, I teach at the university, he tells his graduating students, if you're not going into audiology, maybe you should become an HIS. How could he do that? He's going to destroy our field. Like, no, stop it. There are some people that don't have the time, certainly don't have the finances. Maybe they also don't have the grades. Maybe they do have the grades, but don't have the time or the finances, right? Like, we can't just kick people or segregate people out of our field because they don't meet some arbitrary bar of education.
Yeah, we need the support. We need in our clinics, we need to expand, and we need to expand our perceptions of what we can and cannot do. I mean, I think I had a Miracle Ear franchise. I hired people, I trained them. I was their oversight. If I saw something on an audiogram, I'd say, next time you're out there, can you do this with masking this time? So, and that was a long time ago. But I got a lot of flack for that. I had people telling me they were going to close me down, audiologists. I was surprised. Yeah, we have to quit killing each other and march in the same direction together in order to win this war.
Somebody pretty important that I was just with a couple of days ago said to me, I've worked in a lot of medical fields, but audiology it's like the high school cafeteria. There's nothing worse. But look, there are people who have the right vision, and I love that. I had no idea what to expect. I'm going to be completely honest with you, Kathy. I've done a lot of these interviews. I think this is the greatest interview that I've done. I think that this has been the most enlightening and surprising. And you can go watch all my podcasts. I've never said this before. I am so grateful that I got to meet you and got to hear from you, and that you were willing to come on the show and share your perspective.
Well, thank you so much for the opportunity, because spreading this word and realigning people's thoughts on how we move forward together is so important. Yeah. And it's a blue ocean. It is wide open, what we can see.
Somebody's read that book, Kathy.
Yes.
Great book.
Yes.
Kathy, have a great day. Thank you for all you've done and all you continue to do. Please don't ever really retire.
Oh, thank you. I don't know if that'll happen or not, but.
All right, you take care and have a great day.
All right. Thanks so much, Keith.